Good afternoon, everyone. This is Anthony Alaka with Torrey Hills Capital, and I want to welcome you to the StageZero Life Sciences webcast for January 25th, 2023. Happy New Year. I hope everyone's doing well, and I want to thank you for taking the time to join us today. It's been almost a year, maybe 10 months since we first brought you StageZero Life Sciences. A lot has happened since then, and we're excited to have management on with us today to give you an update on the company. Just to refresh your memory, StageZero Life Sciences is a vertically integrated healthcare company positioned to be an industry leader in the early detection and management of a wide range of cancers and other chronic diseases. StageZero's comprehensive platform for detection, treatment, and prevention will be instrumental in greater overall survival rates and healthcare cost savings. StageZero trades on the OTC market under the ticker SCLSF and on the TSX exchange under the ticker SCLS. Company shares are trading with a market cap of roughly $5 million US. And based on the size of the addressable market and the company's opportunity for growth, we definitely feel that there is potential for upside in the stock. With us today to discuss StageZero Life Sciences and the company's strategy going forward, it's company's chairman and CEO, James Howard Tripp. We also have head of investor relations, Rebecca Greco, on with us today. Hello to you both. It's great to have you on, and thank you for taking the time to get our viewers up to speed on StageZero. Obviously, a lot of exciting things have happened since we last presented the company. Before we get started, and I turned it over to James, I just want to mention all of our viewers know the format here. So if you have a question, simply type it into the Q&A or chat box, and we'll make sure that it gets answered. If you can't do that, click the raise your hand icon, and I'll unmute you so you can ask directly. So with that, I'm going to turn it over to James, who'll take us through the presentation. If you have any questions during the presentation, type them in. So with that, James, the floor is yours.
Great. Thanks, Anthony. And hi, everyone. Thanks very much for joining us. I believe it's a mix of people that we've spoken with before, as well as people that are new to the story. So I'll do a little more comprehensive review of who and what we are, I think, just to get everyone up to speed. As usual, we'd ask you to read the forward-looking statements and to bear that in mind as we move forward. Next slide. So who and what is StageZero Life Sciences? And I think particularly going to Anthony's point about doing a recap of the last 10 months. So about 15 months ago, we actually acquired the group called Care Oncology. Care Oncology is a clinical group. It's comprised of oncologists, specifically with a focus into the metabolic side of cancer care. And it's out of the UK as well as the US. And their claim to fame really is the Care Oncology protocol, researched over essentially about 20 years, and whereby it is looking at a number of interventions to essentially work with together hand in glove with standard of care to improve outcomes. And I'll explain a little more of that. If you look at the pivotal metrics study, which is what they did initially, it was done in glioblastoma patients, and working alongside standard of care, they essentially doubled survival rates in the first 18 months of treatment. They're about 5 years out in terms of that particular study, and we've continued to show improvement. We'll very shortly be introducing a new version of the Care Oncology protocol, very much evidence-based, very much with hard endpoints. And I'll expand on that a little as we go through. But we did that because I think as we were embracing the market or looking at the market together with Aristotle, we saw employers as being one of the key areas that we wanted to go after, and employers told us several things. Aristotle was great, really nice product. As you get positive, Aristotle would essentially tell you whether you have cancer today, yes or no. However, if we tell you you have cancer, what do you do with it? Can the patients get triaged? Can they get help through? As we deal with tens of thousands of patients, how do we manage this? How do we go back to their own physicians? And you take that into the employer sphere, and our focus is really on employers. Right now, I would say 500 to probably about 40,000 in terms of employees. It's a lot of people to deal with. You need a clinic or a clinical group to triage this. That was care oncology. In addition to that, there's a secondary piece. What about cancer tomorrow? What about developing cancer tomorrow? Can we plot those pathways? If 40% of cancers are truly preventable, what can we do about it? So the final piece to this was to say, are there risk modification programs that we can introduce to actually work with these group of patients, and not just in chronic major diseases, but also in preventing cancer? And that is the final piece that goes with what we've developed. So over the last sort of year, we've fully integrated the group, we've aligned the programs, we've integrated the programs. We've taken them out. We will show you work that we're doing with firefighters, for example, and we are engaged with employers, large employers. We're engaged with insurers and reinsurers, and we're doing work with healthcare systems, for example, hospital groups. And so we'll expand on that. So who and what is StageZero in itself beyond the care oncology piece? We're actually one of the pioneers of liquid biopsy. We're one of the very first groups to have started in this field. And as a result of that, the platform that we built is extremely well validated. It's been used in over 100,000 commercial patients in the US alone. And so we add to that all the time. And it's a very definite advantage to have a validated platform. The second thing is Aristotle is absolutely unique. And I will explain that in great detail as we go through it. We're a CAP accredited, CLIA certified, high complexity lab. There are about 200,000 labs in the US. Only about 2,000 of those have the designation that we have, which is the highest designation you can get. We were recently CAP audited. We passed with flying colors. And so we're very proud of the fact that what we do is good and consistent. We have world-class clinical and scientific specialists in this. If you look at the US, we draw from, for example, the VA, we draw from MD Anderson. If you go to the UK, we draw from the London groups of hospitals, Barts, for example, and King's College, a whole series of those. So absolutely top class in terms of who we work with. And key with all of this is we developed very early on a global telehealth program, and telehealth is utilized about 60% of the time. Going into COVID, utilization was more like 12%, but we believed it was going to grow. COVID came and dramatically increased the utilization of it. That has continued through. It's settled into the range of about 60% at this point. And it's an absolutely critical piece as you work with employers. Employers want their employees to be able to get to you at any time, in any place. And the only way you can do this is to have a validated telehealth platform. So we have all of those. And then the programs that we talked about, Aristotle, multi-cancer test. AVERT is our early detection and prevention program, and TREAT is the one that goes together with standard of care in terms of looking for better outcomes on your cancer. Next slide. You look at the current situation, and I'm going to focus very heavily here on employers as we go through, but tie into that insurance, reinsurance, and then from there to healthcare systems. But cancer, you probably know this better than even we do, is currently the number one cost driver. It's also the number one cause of death. And so part of this was not only because that's where it was going, and we've got an aging population, but together with the fact that COVID severely disrupted everything. Breast cancer screening, for example, came down to about 4%. Colorectal cancer screening was in at about the same area. We're coming out of, or mostly out of, the sort of COVID bubble, but we're faced with an absolute deluge of late-stage cancers. And late-stage cancers being found because essentially the people are symptomatic. So everyone knows you have to get back to screening. You have to get back to making this work. And we'll talk about the cost drivers in a moment. The national economic burden is staggering in terms of where you look at it, 150.8 billion. And part of that, you can't just think about the cost of treating the disease. You've got to think about time off work. You've got to think about medications. You've got to think about the support programs. All of it ties in. The other thing too, it has an absolute major effect. Developing cancer has an absolute major effect, not only on the patient, which is obvious, but on the family within all it is. And a thing that I think totally surprised us is that, first of all, it's the #1 cause of personal bankruptcy in the US. And as you can see, the statistic there, you're 2.5 times more likely to declare bankruptcy. So anything that we can do to reduce cost or improve outcome is absolutely critical. Next slide. Finding it early is in some ways an obvious, but I think this is what sort of really brings it home. And so if you look at 5-year survival rates, you can see how different it is. We very typically always talk to colorectal cancer, where essentially if you find colorectal cancer early, you've got about a 90% chance of surviving 5 years. You find it late, you've got a sort of 10 to 14% chance of surviving 5 years. 2/3 of colorectal cancers are found late. So even with all the screening programs that go on, 2/3 are found late. And there's a reason for this. People don't want to have a colonoscopy if they don't have to. And a lot of the tests, the stool tests, in actual fact, miss a lot of the cancers because right-sided lesions, in fact, in this are the most aggressive. Stool-based tests mostly miss right-sided lesions. Women mostly have right-sided lesions. So you've got to have better ways of doing it. And then you can work down all of the others. You look at breast cancer, you go from 99% 5-year survival to 28%. You go to ovarian, which is one that I particularly hate. It sneaks up on women. It's difficult to find. There's no general screening for it. But when you have it, the outcomes are generally very poor. And so being able to find it early, 93% 5-year survival, 31% if you find it late. And so you can walk through it. And so as people look at this chart, I think they go, gosh, we have to find it early. Next slide. The next piece is the cost savings aspect of finding it early. And if you look at all of this, typically there's a 2 to 4 times increase in the cost of treating a late stage cancer versus an early stage. So think about it for the individual, that's critical, but even more importantly, think about it for employers as they go through. And when you think about employers, you have to link in reinsurers, because we'll talk to the reinsurers at the exact same time that we talk to the employers. Why? Because employers, a lot of them being self-funded, we'll work through those stats at the end, but almost 2/3 of employers in the US, for example, carry self-insured or self-funded insurance plans. If you look at costs on all of this, they will look for, actually, if you talk to them, if you can show them a 2% reduction in costs, they want to talk to you. You'll see that as we talk about breast cancer, we're showing a 58% reduction and then in costs, and that's just a single cancer. So do we get attention? Yes. Do we get a seat at the table? Yes. And this is just to reinforce all of that. You have to find it early. You have to have the impact. The reinsurers want us there because what do the self-insured companies do? They lay off the risk with the reinsurers, and so the reinsurers carry that particular cap. So everyone has very vested interest in finding it early. Next slide, please. We're these 3 pieces. And I think, as I mentioned, Aristotle is the early cancer detection. It finds the cancers individually, it finds them discreetly. It also screens against a variety of other diseases so that we know it's quite specifically cancer. AVERT is the program that we've coupled together with it from the care oncology side, and that looks at the metabolic pathways, and that would indicate whether you are potentially developing or likely developing cancer or the major diseases that often precede cancer. And of course, that allows us also to introduce the risk modification programs, also lies under the AVERT banner. Treat is, as we talked about from the glioblastoma study, treat is the adjunctive care that, the adjunctive therapy that goes together with standard of care. And that is to look at improved outcomes in all of this. Next slide. This is Aristotle in detail. On the left are the cancers we look at. No, we're not trying to do 40 or 50 cancers. We don't believe that's the right approach. We will build out and are in fact in the process of building out probably to about 14 or 15 cancers. They are mostly those that are accepted in terms of standard of care and screening. We think that is critical at this point. It's also very difficult with the more esoteric cancers to actually have really good results. And so we're going to stay much more narrow in terms of where we are. But what what Aristotle is we would take a single sample of blood from you, and then we would run it against the mRNA profiles, gene expression profiles for a cancer. So in this case, it would say you definitely do have colorectal cancer, or you do not have colorectal cancer. It's very discrete. And it's discrete. If it tells you that you may have colorectal cancer or may not, it will at the same time tell you that you do not have any of the other cancers, because we are comparing them one against the other. In addition to that, as we developed the whole liquid biopsy approach, we did a lot of work in the CNS area, a lot of work in the GI area, a lot of work in the autoimmune disease area. And as a result of that, we can contrast all of these, because bearing in mind, finding a signal that would say it's colorectal cancer could be fairly close to Crohn's disease, could be fairly close to rheumatoid arthritis, could be fairly close to stomach cancer or bladder cancer. So you need to be able to differentiate. And this is very different in approach to what a lot of the other groups are doing, whether, for example, it's GRAIL or whether it's Exact Sciences, because they're utilizing circulating tumor cells and then very often methylation. Two aspects with that. Circulating tumor cells are difficult to find. Your methylation changes, in fact, accumulate over time. So they're much more effective at finding late stage cancers than at finding early stage cancers. We beat them hands down when it actually comes to finding the cancers early. The second piece with this is because we're discrete, we work through exactly what I was explaining to you. They do not. They will rank order the cancers. So they will go, we believe that it is this cancer first, that cancer second, that cancer third. And that is because the signals are not absolutely discrete. And so there still is a fair degree of searching that has to go on before the diagnosis can be made, whereas in our case, we will point you directly to it. You're getting a lot of other approaches. You're getting ultrasound, you're getting full body MRI. We've got a whole lot of things going in. Criticism around all of them is, one, they provide a lot of false positives. But two, in addition to that, they are not discrete. And if I take through a discussion we had with the Atomic Energy Board, for example, the tests they've been employing to actually screen the individual employees, if it flags as a positive, it can take them up to a year and up to $50,000 to actually run it to ground. And sometimes quite of that work is quite invasive. So what people are looking for is tests that actually are as discrete as possible, and tests also that go as early in the cascade as possible. We are developing within this the differentiation. So we focused on colorectal cancer to begin with. And so right now, if we did the colorectal cancer test on you within Aristotle, it would say whether you do or do not have colorectal cancer. The test that we're bringing up second to this right now actually separates it, first of all, into early versus late. So stage 1, 2 versus stage 3, 4. But even within stage 1, 2, for example, we're separating it out. So that stage 1 or stage 2. And then we're also adding polyps. So, for example, we could tell you whether you have polyps, which are not yet malignant, as they lead to potential malignancy. What we found when we developed the first of the colorectal cancer tests around this is that by telling the colonoscopist that we believe there is something there, they get anywhere from, I believe it's a 2.1 to 4.7 times improvement in finding the lesions, particularly if they're on the right side. Why? Because we've told them it's there, therefore go and find it. And being able to do that, particularly with early lesions and particularly with polyps, is really critical. So we believe that stands us in very good stead. And then again, because as I mentioned, this is a platform. As we add the additional cancers, we don't have to validate the platform. It's validated, it's out there. All we do is we actually validate the individual cancers. And we're moving down that path right now. As I say, as we're expanding out to essentially it's going to be 14 or 15. And one of the things we're just starting, glioblastoma will be within that, lung will be within that, pancreatic will be within that. But we've also just started to focus on the blood cancers as well, myeloma, leukemia, for example, because we're getting very strong demand for that. And we believe we'll have a very particular advantage in that space. We can also typically, as long as we have sufficient clinical samples, we can bring these forward pretty rapidly. Next slide. AVERT, as it says, addresses tomorrow's cancer today. So if you had one of our oncologists speaking with you at this point, for example, Dr. Vamadavan, Pad would tell you that cancer virtually never arises without a major chronic disease being present. So one of the first things that flags through is the metabolic pathways that drive to that. What our group does is they screen you for all of the metabolic pathways. It's how the Care Oncology protocol works. And they will flag whether you're likely on the path to developing cancer or not. They will then work with you to actually bring those pathways into balance. And that's where we get this 40% preventable cancers. And that's not our stat. That's an acknowledged stat out there. Key within this, though, and think about insurers here, think about employers too, is that we will flag the potential for you developing major diseases. Let's just use metabolic syndrome, for example. So metabolic syndrome, big issue. About 2/3 of Americans will probably flag as having metabolic syndrome. Depends on where you lie, and you will flag as perhaps green or amber or red, depending upon how we look at it, and that will indicate the level of interference or intervention that we need to have. If you have metabolic syndrome, you're potentially on the path to developing diabetes. If you're walking down that path, you will likely have increased insulin resistance. A thing that's been somewhat known, but typically not worked with, is the fact that if you have an increased insulin resistance and you have one, you're more likely to develop cancer. You're also more likely to develop a series of other diseases. But in addition to that, if you do have cancer, if you are diagnosed with cancer, at the point at which they introduce the chemo, let's say it is chemo that they put you into, you are going to respond less well to the chemo. You're going to likely have a higher incidence of side effects, and your normal cells are going to recover less quickly. As a result of that. So therefore, measuring one, finding the insulin resistance, two, dealing with it with strategies to get you normalized is critical. And this, for example, is part of what underlies what we did in the glioblastoma study. Now, we've got similar case studies in breast, in pancreatic, in colorectal, in lung, you name it, as we go through. And so that is only one of the pathways that we look at. We look at about 20 pathways and deal with it. And so there's increasing recognition here that cancer therapy is not optimized. It'll be groups like ours that we, in actual fact, will begin to help optimize it. I sat with a very, very prominent group of cancer hospitals just a couple of weeks ago, just talking through all of this. And their frustration is that they spend about 80% of their resources looking for about a 3% improvement in outcome for the patients. And as they were saying, something's got to change. And they said, my word, if you guys can come through on all of this, they said, this is the major breakthrough that everyone's looking for. So that's where we're going. So not only we'll find tomorrow's cancer today, but we can absolutely put the interventional programs in place to try and prevent you getting there. And then, Rebecca, I've actually covered the next slide too, which is treat. Go one more. No, doesn't matter. Go back if you will. Sorry, thank you. Yep. So on the treat side, it covers that as well, which says, okay, we actually can work with the patients all the way through. So it's what employers want. We have this unique setup to be able to do it, but it's also what the insurers and reinsurers want. And will you just go to the next slide, the pinwheels? Because when we showed this to the reinsurance groups, they said, you've got to talk to the insurance companies. And we said, okay, we plan to do that. And we said, why? And they said, because absolutely what the insurance groups do is they want to know, particularly for people that take fairly significant policies, they want to know the risk profile of those particular individuals. So again, we're novel. We've got Aristotle, Cancer Today. We've got the AVERT program, which you would look at here, for example. And as you work through that, it would tell you where you have risk factors. That would increase your premium. Not a good thing, but a good thing from, not a good thing for the individual, but a good thing for the insurance company. The next question they said, sorry.
Sorry, I was just going to ask you, so just looking at this chart here, or this slide here, so for let's say kidney health on the bottom right, obviously the green, the green full circle is someone who is completely healthy, correct? In their kidney health.
Yes,
okay. So
that's correct.
Can you talk about what let's say inflammation on the top within range 50% versus what the yellow and red circles might mean?
Yeah, no, that's perfect. So green is exactly that. And so this is how, bear in mind that with Aristotle, you're going to get a readout that says you have this cancer or no, you don't. With AVERT, you're going to get this set of readouts. And across these various groups, bearing in mind, as I said, it's about 20 different metabolic pathways that we're looking at. They tie back into all of this, and this is how we would present it back to you. So let's presume you're the company employee, you've tested negative on Aristotle, which is a good thing, but you actually have a panel like this. So the first thing we would do is we would sit with you and we would start and work from those that are entirely green, like kidney health, which I think, as Anthony explained, is to say, no, everything looks as if it's all in line. There are no red flags. If we move right up above it to the metabolism piece, and remember, metabolism there likely ties into metabolic syndrome, leads towards leads towards diabetes. As we go with it, we would tell you that about half of what we're looking at is within range, about a quarter of it, which is the amber, we would say is flagging amber. It's not yet red, but you do have to work with it. And we'd say about a quarter is red. You've got to deal with that right away. If you don't deal with those right away, these are the potential consequences. And then what we would do if you tie in, and as we're speaking with companies, they say, okay, we'd like to put the employees into the programs as well. They come into that. We would then give the employee a program which would involve a series of meds. It may involve diet, it may involve lifestyle changes, it may involve a whole series of pieces like that. But we would then come back, and what we do is we actually track them on a quarterly basis. If you're purely in the preventative side, we would probably run this on you once a quarter, and you would have in-depth series with one of our oncologists, and or from there to a dietitian and the like. So that is, we work to bring you fully to green in terms of ways. Should you develop cancer while you're on this, and bearing in mind that we run this program together with people that have cancer as well. So if you have cancer, we would run it through. If you go to you can tie inflammation and metabolism together here. We will be looking at within that, let's say, the insulin resistance aspect I was talking about, and we would work to make sure that we bring your insulin resistance into line. We do this with your standard of care team. Why? So that we can make your chemo more effective, so we can give you fewer side effects, so we can help your healthy cells recover more rapidly. We would do that. Those are the things that have led as we go to these improvements in outcome. And we'll do that for each and every one of these pinwheels. Bearing in mind that if you're on chemo, kidney and liver health, absolutely critical. Cardiovascular really is just a nice to have, but because we run through all of these, it would be typical. Anthony, that explained it well enough?
Yes, yeah. Thank you very much. I just want to note too that, when you look at all, inflammation and metabolism and liver health, cardiovascular health, most of those can be handled early on with intervention through medicine and or diet and lifestyle modification. So it's very important, to be able to flag those risks as early as possible. So that's a very comprehensive, readout report, whatever you would call it. So that's great to know. Thank you.
Yeah, no, you're welcome. Rebecca, next slide. There we are, thank you. And this is just to explain, we've covered this well enough, I think, but it's to explain that, yes, you will pick up a lot of additional diseases. It's not we're primarily focused on cancer or developing cancer. But as I said, you very seldom develop cancer without having an underlying chronic disease, which may be there and undiscovered. You don't always know about it, but it will be there. This is a way of actually being able to flag a lot of this and deal with it. And I think this is the key bit to why our organization is structured the way it is. Next slide. So this is why we're different. So it's exactly that. Aristotle on the one side, Avert on the other side, the actual clinical group in the middle of this. Clearly on the Aristotle side, if you get a positive cancer signal, you're going to go through the telehealth triage. You'll get handed off to an appropriate pathway that will get you worked up should you have cancer. And then from there, you can choose whether to enroll in the treat program or not. You don't have to, but you will be given the option. You'll be given the benefits out of it as well. Now, bear in mind that from a employer's perspective, there's an advantage to having patients into all of this because you keep them healthier, you keep them with fewer side effects, you keep them at work a lot longer. All of that works extremely well. And I'll tell you, as we're working with firefighters, this has been one of the key reasons as to why they've got together with us. We're literally the only group, I think, at this point that can provide this. Clearly with Aristotle, you've got a negative cancer signal, that's fine. We'll see you again next year for this. But you will then move or should move through the Avert screen. If you go through the Avert side, it's the panel and a very comprehensive patient history in terms of where it is so that they tie it all together. This again runs through all of the oncologists. So it's not running through primary care. This is running through this very specialized group of metabolic oncologists, so that it is known and understood through all of that. Clearly, your panel results are reviewed, and we then work through. And again, this is where the telehealth comes in. If you have, for example, one of the physicians that I'm thinking of here, he's out of King's College Hospital in London. He's a worldwide expert in hematology, so blood cancers. So if you're in that area, it may benefit that we actually have you talk with him, and he would work with the US physician and drive it through. On the other hand, if it's lung cancer or it's prostate cancer, we have physicians in this that maybe have that as their primary specialty. And so what we will do is we have an ability to actually direct you within the process like that. And then obviously the patient too can tie into the preventative program. Next slide. So what's the pitch here, I think, in all of this? If we look at employers only, our focus is employers first, target market, employers first, insurance and reinsurance second, or I should really say reinsurance and then insurance second. And then third is healthcare systems. And the reason we put healthcare systems is because it's generally a longer pathway to work your way through all of that. But if you look at the employer market, the self-funded employer market, which is what our focus is, US alone, there's about 157 million workers, employees, or people that are covered under some form of employer healthcare program. Of that, 64% are in covered self-funded arrangements. That's more than 100 million Americans. So it's an extremely large market. We find that the largest group of self-insured are in the 500 or more employees. And as I say, our sweet spot, as we've looked at it, is really sort of 500 to about 40,000 in terms of where. We have had discussions with one group that has in excess of 100,000, but obviously that again takes time. You've got to pilot it, you've got to run it through, and then you've got to have a significant footprint on the ground to do it. I'll bear in mind too that as we do this, we are used to doing this. We take teams into the employers, they draw the blood there. They the tests are all processed in the lab in Richmond, Virginia. That's Aristotle, so single source. That's the clear and CAB certified lab. The metabolic pathway panel tests we actually run through Quest. So we have a US-wide agreement with Quest to actually run that through, and we do it. We are very used to doing this. We honed this skill. We were setting it up just before COVID hit. COVID essentially pushed everything sideways. And however, what COVID did with us was it allowed us to actually test all of our capability in the space. And for example, we were the primary COVID tester for the Maricopa, so the county of Maricopa, which is the fourth largest county in the US. We looked after pretty close to about 50,000 employees, I think, at the end of that. At times, we were screening patients, testing patients for COVID 6 days a week at 5 different locations on any given day. And we were running 3 stations at each of the locations. So clearly, we have the logistical capability to do this. We know how to do it. And so, yes, if you're the employer, we will come to you. We will draw blood there. As we deal with firefighters, for example, we do the crossover between shifts, sort of early morning, and we will go into a particular fire hall, a group of fire halls for a week, and we will draw all of their people there. So that's how we do it. Next slide. This is the case study on treating early stage breast cancer, and bear in mind that we do multiple cancers, so this is only one, but it was to provide an absolute example. And so what we've done is we presumed that it was 1,000 women within the company. We presumed that they would go through their normal mammograms, and be careful, mammograms are nowhere near as accurate as people have thought they are. But we've given it full credibility, and we've said, okay, let's work with only those that did not get screened, chose not to get screened, and we've taken it through. So you go from 1,000, 129, you would expect within that to actually test positive. 84 were screened out on mammograms, leaves 45 that were not screened out. You look at your average treatment cost because we're finding it early, which is the advantage here, and you can see what your difference in cost is as you go. It actually gets even bigger if you presume that mammograms going to miss a whole series of the cancers, or that fewer women will actually get screened, and which just increases the delta. And it means by running it through our program, because we come to you, we do it where you work, that in actual fact, the achieved savings are even more significant. And you extrapolate this across the 9 different cancers that we do across the workforce, and savings, as I spoke about in the beginning, a 2% reduction is what all of the employers would absolutely accept. You do much better than that. You tell them that you can do it in double digits, and they absolutely want to speak with you. So this is the program that we have in front of everyone right now. Next slide. This is an example of what we're doing in Ontario. Sort of blows your mind, but 86% of all claims for firefighter work-related deaths is from cancer. I'm going to say that again, 86% of all claims. In the US, the equivalent statistic is 66% of work-related deaths. It's a slightly different statistic, but 66% work-related deaths are due to cancer. So for firefighters need to get screened, but it also applies to airport workers, it applies to pilots, it applies to UPS and FedEx drivers, it applies to steel workers. They're all of the groups that work in this, it's very high. In Ontario, there are about 30,000 firefighters in total. And in addition to being screened to make sure that we find it early, because almost always these cancers are being found late, and the cost to the cost to workers' comp, the cost to the unions, the cost to the actual states, the provinces, is exceptionally high. The numbers, the costs are actually mind-boggling as they work through it. So they not only want them screened, but in actual fact, it's looking at how we gather data. What impact do different fires have? Is a chemical fire worse than others? We had such a situation in Boston a few years back when we were screening firefighters there. They had attended a particularly nasty chemical fire. About 5 years on, they were seeing a higher incidence, what they believed was a higher incidence of cancer in people that had attended the fire, but they had no clear evidence around this. This is the kind of thing that we'll be able to do. We're getting, again, going to the US, we're testing firefighters there now. Within all of this, a group of 500 within a cohort of 4,000. In actual fact, are ex-Air Force, but they're Air Force Afghanistan, and they were in what's called the hell pit. And so they're saying, right, they were exposed to every noxious chemical you can think of. Do they carry higher risk? And so they came out of the Air Force and they joined the fire service. They want to track these people. They want to see it. We know that we can track one fire hall versus another, one state versus another. We can look at different training methods. And so we've got a very comprehensive ability to not only screen across the programs we talked about, Aristotle and Avert, but we can compile all of this data and give it back to them. And so that's part of what we're doing as we go through it. Next slide. So how we're doing it is exactly as we talked about. They're doing both Aristotle, which is Cancer Today. They're doing the Avert Metabolic Pathway Panel. for cancer tomorrow. We're using our oncologist supervised program. We're using it via telehealth as we've set it up. We are going to the fire halls, as we've talked about, in order to get them screened. We're doing it at the crossover of the shift, which is about 8 o'clock in the morning, which is the best way to do this. We are working on the health economics side to actually pull this all together, because we can have, or believe, or certainly believe, we can have an absolutely major effect on cost in terms of dealing with all of this. And in actual fact, a very interesting thing that they've done on the Ontario side is, if the fire halls did it independently or the union did it independently, they kind of one-offs. You do it now and then you've got to fight for it all over again next year. By taking it in through the cities, because the cities actually fund all of these, they put it into a multi-year budget. So in other words, it's in and it goes. And so it's taken a little longer to get it up and running, but we're beginning with all of this right now. So it's a very strong program that can build the data out as we go year after year.
And how has the feedback been so far?
I'll show you next.
Okay.
Oh, it's been very positive. It's truly been very, very positive. And oh, apologies. I thought I had a slide in here that actually showed some of the results. I'll just cover that a little bit. We should expect in a typical population like this about 2 to 5%, somewhere in that range. You can narrow it down closer to, let's say, around 4% of the individuals should test positive, right? They're high risk in terms of all of this. You would expect that. So as we've done the analysis across the first of the groups, as we've gone through, we're exactly sitting about 4%. So we're right on the mark in terms of what we're finding. So we're not just finding the cancers, as the sort of full diagnostic aspect comes through and we follow it all the way up, we'll be able to sort out how many early, how many late, etc. But at least at this point, we are performing absolutely right where we expected to perform. And we are finding cancers in young people, which I think is what has surprised people. Is that, you know, what have you got to cover for? It used to be you had to be 50 years of age and at least 10 years worth of service to even get screened. We've now found that that's not true. We're picking up cancer in 31-year-olds. And so it's actually opening up this entire box so people can look at it very, very differently. And so as we've taken that into cities, the approach from the cities, I must have been involved in, I think, about probably close to 20 meetings with the groups like that. We've not been turned down once. Everyone, and we do it together with the firefighter group, and they've immediately gone, this is great. We absolutely have to do this. If you're spending $1 million or a couple of million a year just on the benefits of managing this, again, if we could provide you this kind of reduction in cost, it is huge. The second thing with all of this, as it drives through, is if you've got a 60 to 80% chance of dying from cancer as a firefighter, and you're not screened and you're looked after, people are concerned that we will stop getting firefighters. Police carry fairly close risk. Ambulance, the emergency response, again, fairly close risk. So as this becomes much, much more public, you get the unions involved and you also get reticence to join. So all of this, these are drivers in it. But cost is a huge one. So I think in summary, again, going back to employers, you know, cancer is now the #1 catastrophic cost for self-funded healthcare plans. Remember that in the US alone, that's about 100 million people. The early cancer detection, as we talked about, has absolutely marked effect on costs, but it also very dramatically improves 5-year survival rates. And that's going to get even better if we can pull them into the treat or avert programs as you drive it through. A very high percentage of cancers are fully preventable. We need to do a better job of that. Everyone knows that's where medicine is going. We're one of the leading groups in terms of this, and I think particularly as I talked about this whole adjunctive aspect. I think about it a little bit. I'm ex-Big Pharma. In Big Pharma, everything we did was to get the drug to market as quickly as possible. You never had time to actually optimize dosage. That led to the entire industry that was drug delivery, as everyone started to work with now actually delivering the drug correctly. We're probably at the leading edge of a little bit of that. If we can do with chemotherapy what we believe we can, or what the hospital groups believe we can, think of the effect that we can have. And we've got 20 years worth of research with proven data to at least begin that path. So it's huge. The companies with 500 plus employees are the target, as I said, 500 to 40,000 in terms of where we go. And we really adequately demonstrated that we can provide a significant cost reduction. The cost reduction doesn't have to be 50%, doesn't have to be 10%. It's got to be better than 2%. We're better than all of that. And that's where we go. So right now, I think, just concluding this, I think people are aware of the fact that we raised, but we did the deal for funding a little while ago. Right now, it's been a matter really of putting the funding through to make sure that we're building out mostly on the commercialization side, to make sure that we're driving this as hard as possible. But it augurs well for us actually having a really nice year. Happy to take any questions.
Yeah, thank you, James. Very comprehensive presentation. You covered a lot of bases there, and obviously the key to the name of the game when it comes to cancer is early detection and prevention. And so the cost savings is extremely impressive, especially when you consider how badly these self-funded insurance companies need this. I'm going to open the floor to questions from our attendees. If you have a question, the easiest way to ask is to simply type it into the Q&A or chat box, and we'll make sure it gets answered. So James, we're waiting for some questions to come in. You mentioned the financing. You have access to a substantial line. How much of that do you think you're going to have to dig into before you can get to break even or possibly, profitability, moving forward?
Yeah, good question. I'll probably break it into two parts. So the first thing is we're actually not that far off of profitability. I think people that are used to us, we typically try and move a little ahead of the curve. So we coming through the acquisition, our approach was actually to essentially keep everyone on board. We didn't want to panic anyone. We wanted to really learn the business. But then as we've moved on through that, we've done that normal sort of 35-40% reduction in internal costs, which is what you often do with acquisitions. So we've actually brought our organization down into what we would regard as absolute fighting shape. So one that accomplished in actual fact some time ago was accomplished about the middle to third quarter of last year. And then we've been driving incremental revenue. So as a result of that, we're really not that far. We're in very reachable distance of breaking even. So the need for the funding, because of where we've sat as an organization, if we were purely NASDAQ listed and has been and always had been, I think we would have raised larger amounts of money. Being on the Canadian side of the border, you typically raise smaller amounts of money. So therefore, it's been the constant process of raising money and then driving the company. The reason for doing the larger raise this time, or have access to the larger raise, means that if we need it, we can take it. We have no intention of immediately going out and trying to draw large amounts. It's not that at all. We'll actually pace it commensurate with what we will believe is incremental share price together with what we need. But right now, it's literally all about building out the commercial approach. So that's where we go. We have everything else we need. It's purely making sure that we fully execute on the commercial aspect, and initial outreach, initial response, as we've talked about the firefighters, all of this, we've done extremely well. And with the team that we have, it's pretty experienced.
Yep, that's great. So, obviously when you're dealing with a very large self-funded group, or if you're dealing with, a city, those contracts can take a lot longer in terms of, negotiations and things like that. We all know how these bigger organizations, how slowly they can move. But do you feel like 2023 could be a year where you do announce some significant contracts that have meaningful revenue to the company? Because with only a $5 million market cap, you don't really need to sign a huge deal to push the needle, but to see some revenue generating contracts coming in, obviously would be a game changer for the company in terms of the stock.
Yeah. So we've been at this for about the last 6 months. So in fact, some of it maybe last 6 to 9 months. So the time frame for feeding it into budget discussions, etc., is to a large extent mostly through. So we will start to see, if we talk about Ontario, for example, and the firefighters, we will start to see a whole series of those go live in the next short while. So that part at least is good. The other part, we actually have some substantial agreements with groups, but the groups won't let you go public. No employer actually wants their name out there in terms of trying to have you promote. So we will do some things. It's perhaps more on the sort of insurance or reinsurance side where they would like to talk about it. But I think the evidence will be more in the revenue. So as the revenue begins to jump, I think people will go, oh, okay, clearly there's something there. And then as we go through, we'll talk about it. So it's going to be a little bit of a mix of that. But you're right about the 5 million market cap. Yes. By all accounts, everyone we speak to on the US side of the border, their first question is, how on earth can you guys just have a 5 million market cap? Well, that's what we're trying to change.
Yeah. And, last year was, I think, a tough year for all the markets, and especially for capital markets in terms of raising money. But, like I mentioned, it wouldn't take a lot to really move the needle here and push the stock higher. So you're obviously looking at some other high risk, professions as well. Like you mentioned, police officers, potentially the military with, through the government. I mean, is that something that's not really on the radar yet, but is that something that you're looking at?
Yeah, no, discussions through DoD, discussions with the VA, all of those absolutely appropriate. Quite often when we deal with the cities, so if I go to one particular state where we're testing, let's call them first responders, it's a mix of fire, police, and ambulance.
Yeah.
So they are all coming forward from that, and in this case, this actually is paid for by the state, and so the initial group, as I spoke about, that's where a lot of that has come from. So those are there. Insurers, reinsurers, and a lot of employers actually can move very quickly. They can move very quickly. So some can take long. We worked, for example, 100,000 employee group. Yes, that takes time because you've got to do a pilot and then you've got to do the rest. But employers in the 500 to maybe 10,000 range, no, they actually can move pretty quickly.
Yeah, no, that's great. And I mean, I can't imagine a self-insured company, not wanting to do something like this. I mean, if what kind of pushback are you getting, if at all, or is it just a matter of, setting up a pilot system and moving it through?
Yeah. We're not getting pushback. In fact, we're not getting any pushback on what the program is or how the program would work. I think what we've been dealing with most companies is sort of reemergence post-COVID. I think with so many groups, it was a matter of making sure that they were doing well coming out of COVID and getting their businesses reoriented and working again. And once you got all of that, then you start moving to this. So it's all about timing.
Yeah.
But into the latter part of last year, a lot of that began to really open up. And so it's the ability to now move forward with those.
Yeah, it's nice to have
Yeah.
it's nice to have COVID in the rear view mirror, so to speak. So I think that
Yeah.
definitely makes a difference. Just one more question before we wrap up. Do you think you'll see substantial revenue growth from 2022 to 2023 as you're
Yes.
looking at it now?
Yes.
Okay, great. Okay, so I think we're going to leave it there. I want to thank James and Rebecca for coming on today and providing an update on the company. I think 2023 will definitely be a pivotal year for the company. I think they have a lot of potential, contracts that can be signed, and I think you'll be happy to see that the company is back on track after COVID and what that did to their plans the last couple of years. In the meantime, you can get additional information on StageZero Life Sciences at the company's comprehensive website, StageZeroLifeSciences.com, including details on the company's current cancer diagnostic testing, as well as additional information and press releases. And James is always available to handle calls or questions. So if something wasn't answered today, please feel free to reach out and I'll make sure I get it to James.